Very nice to meet you all over Zoom. So we have a few questions to go through. They're all mainly general surgery, and there will be some covering vascular surgery as well. So we'll start off with the first question. So I think we're going to give you guys around a minute to read the question and answer the question as well. Okay, so most of you have said the answer is C, with D and D being the other popular answers. We'll go on to see the correct answer, which is C. So in this question, you have a 69-year-old male. The indications that you have that the patient is acutely unwell was likely an abdominal cause, is that you have abdominal pain and the patient is vomiting. And the first trigger that is there's bilious vomiting, so there's an indication that the patient might be obstructed. And then the other clues, it tells you that the tummy is distended, and then it gives you the investigation results of a dilated small bowel with a transition point. So all these things kind of are indicating that this patient is likely to have a small bowel obstructions. And we'll talk a bit more about small bowel obstructions, but kind of the commonest cause of small bowel obstructions tends to be adhesions from previous surgery. This is just a link from Quesmed, is that to kind of look at X-ray findings to differentiate in bowel obstruction, which is a talk that previously one of my colleagues has covered. So we won't go into this bit in detail this time, as it was covered in a previous talk. So small bowel obstruction. So the signs that you look out for is tummy pain, and the tummy is distended, bloating or vomiting, and the patient not passing stool or flatus. In small bowel obstruction, when you're trying to gather the history, is you need to ask if the patient has had previous surgery, as it is one of the commonest, as adhesions secondary to previous surgery is the commonest cause. From examination findings, there might be high-pitched bowel sounds, the rectum might be empty on PR examination. If there is peritonitis, that is kind of an indication of a very acutely unwell patient and a patient that is likely to need a surgical intervention urgently. We need to look out for small bowel obstruction because there are complications. It doesn't just, the complications is, that might be kind of a complication into compromise of the vascular supply to the bowel, and the ischemia, which can lead to either perforation or progression of the ischemia into necrosis of the bowel, which will kind of ultimately lead to a more radical surgical intervention, kind of patient needing a surgical intervention rather than just a relief of the cause of the small bowel obstruction. And when we try and think of the causes of small bowel obstruction, with many things in medicine, we try and classify it. So the way to think about it is that there are things outside the bowel that can cause small bowel obstruction, things relating to the wall itself of the bowel and things from the inside of the bowel. So the commonest things are outside the bowel, going to be like adhesions from previous surgery, and kind of an intra-abdominal hernia as well, which is less frequent. Relating to the bowel wall, it mentions here next here Crohn's disease, and that's really relating to complications of Crohn's disease like a stricture, okay, and less frequently appendicitis. And inside the bowel is things, obviously, things arising from the bowel wall, but obviously causing an obstruction inside the lumen of the bowel is like malignancy, a foreign body, or a gallstone eyeless, which is normally, gallstone eyeless just means when there's a gallstone inside the bowel and causing a blockage, and that normally can result from the complication of chronic cholecystitis when there is a fistula, a link from the gallbladder to the small bowel. So when we have a patient that we think might have small bowel obstruction, in terms of investigations, what we'll need to do is do some blood tests. So we do kind of the complete set of blood tests that we would do, things like a full blood count, look at the HB if there's anemia, look at the urea and electrolytes, and also we can look at calcium, because thinking about pseudo obstruction, we need to exclude other causes. Electrolyte disturbances can cause pseudo obstruction, and things like lactate help us in assessment of how unwell the patient is. To help us make the diagnosis, we could do an abdominal X-ray. However, obviously more frequently we do CT abdomen pelvis, and it's very important to do it with contrast, and that's really the best diagnostic test to make the diagnosis and would help us hopefully diagnose the cause of the small bowel obstruction that we mentioned in the previous slide. Things like a chest X-ray, erect chest X-ray, we do it with any kind of acute abdomen to exclude pneumoperitoneum, and a small bowel contrast study, which is gastrographin, that can be kind of used to diagnose the point of the obstruction, but also can be, there's also some studies that suggest gastrographin can help relieve adhesional small bowel obstruction as well. So it could be a study of for diagnosis and also therapeutic at the same time. So in terms of management, how we treat a patient with small bowel obstruction, as with any patient acutely unwell, we do our ABCDE assessment and resuscitation. But essentially, the things that we need to be thinking of is drip and suck, so a nasogastric tube on free drainage, and intravenous fluids, and correcting the electrolytes at the same time. It's very important to be able to calculate how much is going in and how much is coming out, so we need an accurate fluid balance, and to do that we'll probably need a catheter. And if the patient is not with the surgical team, involve the surgical team, and will probably, if the obstruction is not relieved, as in it's not just a simple adhesion of small bowel obstruction that is relieved by the drip and suck management, patient probably need a surgical management. Another type of bowel obstruction is large bowel obstruction, which is a surgical emergency. That's really because of the causes of the large bowel obstruction. Its signs and symptoms are essentially similar in terms of pain and bloating and constipation. However, nausea and vomiting is a late sign, obviously, in large bowel obstruction. And essentially, as we said, it's a surgical emergency to the causes, because you need to be thinking about, when it's a large bowel obstruction, is think about malignancy, and there might be a stricture, which can be either due to malignancy or kind of inflammatory mass secondary to diverticular disease. Other things that can cause obstruction as hernias or volvulus or adhesions. And the management will start off with supportive care. And in the case of malignancy, this is the commoner cause is likely surgical intervention. And if there's quite a significant progression of disease, you have to be thinking about things like palliative stenting. And in terms of volvulus, for example, sigmoid volvulus, we need the decompression of the volvulus with a rigid sigmoidoscope. So just to summarize briefly, when you're worried about small bowel obstruction, think about adhesions and previous surgery. When you think about large bowel obstructions, first thing to think about if there's any bowel cancer. Okay. So, okay. I noticed there's a few questions, but we'll try and kind of deal with them near the end of the talk, if that's okay. So we'll move on to the next question. Okay, so most of you have said answer A, with these two other popular answers being B and E. Okay, let's go through it. So we have a 68-year-old male who's got a history of fatigue and weight loss, of already thinking about, we've got red flags, thinking about malignancy. There's a change, essentially the next sentence is telling us there's a change in bowel habit, okay? Saying that he's cachectic and he's got anemia, and he's got looking like a malignant disease in the descending colon with spread to the lymph nodes, okay? We'll kind of, so this patient has got a disease on the left descending colon, essentially needs that part of taken out. So that's the left colon, so they need a left hemicolectomy. Okay. And there's an indication that there's a spread to the lymph nodes. So it's likely that they will need adjuvant therapy. And that is, in the case of bowel cancer, is most of the time is chemotherapy. But if when it's rectal cancer is when you might be thinking about radiotherapy. So yes, the correct answer is A. So important things. What are the risk factors of colorectal cancer? Is age, hereditary syndromes, which we'll go through in a later slide, alcohol intake and smoking. Okay. When thinking about risk factors, to help you kind of classify them, is think about modifiable and non-modifiable risk factors. The non-modifiable here would be age and hereditary syndromes, and the modifiable would be kind of the others in terms of smoking, the dietary habits, and exposure to radiation. Okay. So there's two classifications that we try and use for bowel cancer. The first one is Duke's. However, which kind of A is kind of limited to bowel wall, with D being more distant metastases. However, more frequently, and I apologize about how where the next slide is going to be, is the TNM classification. Essentially, what we need to gauge, you don't, probably unlikely to need the details of the classification, but we need to know is that T is tumor, N is node, M is metastasis, okay? And T1 to 4 kind of rates kind of the spread of the local disease, and is lymph node spread, but M is kind of distant metastases. And essentially what you need to gauge to kind of to help you answer the question similar to this one is that patients with T1 to T4, N1 to N2 with no distant metastases are likely to benefit from adjuvant chemotherapy. And that's kind of a diagram to help you with the kind of picturize the TNM classification kind of from T1 to T4. Investigations. So obviously there are the basic investigations that we're doing, kind of bloods, identifying the anemia, things like that. These are kind of more specialist focused investigations to deal with bowel cancer. The gold standard is colonoscopy, direct visualization, and taking biopsies and making histological diagnosis of cancer. For patients who are not fit to do a colonoscopy, we think about doing a CT colonoscopy. And for rectal disease, we think about doing a pelvic MRI. If the diagnosis is then made of cancer or there's strong suspicion of cancer, think about CT chest, abdomen, pelvis, and that is really to stage the disease to determine the spread. So before a patient goes on to have surgery, we kind of try and think about what is the radiological classification of the disease in terms of TNM, and we use that, the colonoscopy results, and we use the staging CT body to help us make that classification. And there's the CEA, which is kind of a diagnostic tool, but it's kind of not always very accurate to indicate that there's bowel cancer, but it's kind of a specialist blood test that can be used as well. So this, in terms of hereditary syndromes, unfortunately, you just have to learn them. But the things kind of that you need to learn, these are the three main ones: FAP, the hereditary non-polyposis colorectal cancer, and MRCS syndromes. The things that you need to kind of learn is which gene is mutated in each syndrome, the pattern of whether it's autosomal or dominant or recessive, and in all these three is autosomal dominant, and essentially differentiation in management. So in FAP, in familial adenomatous polyposis, the management tends to be surveillance until adult age, and then the patient has prophylactic surgery because almost all of them will develop malignant disease. In the other two, essentially, the management tends to be more surveillance as well. So, next question. Okay, so most of you have said answered with D, second most popular one being A. Okay. So 69-year-old male, and there's a stoma, and essentially when you're going to go into more detail on the stomas, but you need to think about the location of the stoma. It's in the right iliac fossa, so already we have some indication of what it might be. Telling us it's spouted, and there's two ends. Okay, so already thinking of a loop stoma. okay, and the contents are liquid. So I was thinking that the patient has a loop ileostomy, okay. Now, so that kind of narrows it down to between B and D and E, but kind of, sorry, B and D, not E. And then the patient, the only reason to have it, you would never really do a loop ileostomy in an abdominal perineal resection, which we'll cover now, explain now in a second why you very unlikely to ever do that. So that leaves kind of the only correct answer as D. So ileostomies tends to be in the right iliac fossa. Colostomies tends to be in the left iliac fossa. Ileostomy are kind of the earlier contents of the stool, so they tend to be more liquid. Colostomies, the stool has already gone through some large bowel, so the water, there's been quite a significant absorption of the water from the stool, so the contents tend to be more solid than an ileostomy. Ileostomy is we worry about the contents on the skin, so we tend to get spouted, while colostomy tends to be flushed. Okay, and differentiating loop, which means in a loop ileostomy, see two bowel loops. That kind of table is kind of like a quick summary to differentiate between an ileostomy and a colostomy. Okay, so different surgeries that we have. Let me move this here. Okay, so the top one on the left is the right hemicolectomy and tends to be for cecal tumors and right colon tumors. The left hemicolectomy, which is not done as often, but that's because the incidence of cancer in the left colon is less compared to other sites. Subtotal colectomy, which as we can see the picture is that you take out most of the large bowel apart from the anus and the part of the rectum, and that is tends to be in ulcerative, can be done in tumors, but done more frequently in kind of ulcerative colitis that's resistant to medical management. Same for panproctocolectomy as well, but panproctocolectomy can also be done in the cases of the hereditary syndromes that we talked about, which is done prophylactic in familial adenomatous polyposis, as most of them do develop cancer in the future. Now, high anterior resections and abdominal perineal resections. Abdominal perineal resection, if it's within 8 centimeters from the anus, then abdominal perineal is the choice, and high anterior resections are for sigmoid tumors. Now, as we explained before, is that you'd only do a loop ileostomy is that when you kind of you still have the rest of the bowel connected, or we're kind of thinking about a reversal of the stoma, and you're unlikely to do that in abdominal perineal resections because you have done a proctectomy, essentially taken the bottom out, so you never really need to do a loop ileostomy. The stoma of choice would be a colostomy in an abdominal perineal resection. Okay, apologies, that was a quick overview of all the operations that we do in bowel cancer and some cases of inflammatory bowel disease. Okay. So next question. Okay, so most of you have said E, which is, I think, the correct answer. So let's get through the question. So we have a 55-year-old female. The pain is in the left lower quadrant, and there is some nausea. She's otherwise fit and well, and does report occasional constipation. So that's already kind of the question is telling you that there's something in the background, that the patient has some irregular bowel habit. However, in the acute picture, she has a temperature and is tender in the area of the pain, where she puts the pain. But she tells that apart from the temperature, she is hemodynamically stable. And the question gives indications ruling out a urinary tract infection. So it's telling us what investigation gives us the diagnosis. So essentially E, which tells us that there's multiple outpatient sigmoid colon to indicate that there is diverticular disease. But this patient in the acute picture is likely to be having diverticulitis, which we'll go through in a bit. Going through the other ones, a cochlear stricture, thinking about if this might be a tumor or a narrowing. We don't have an indication from that. There might be might see it in a perforation sort of picture, but the question is saying this patient has a temperature, but otherwise is well. So there's no indication that that's the case. The pain is not the area where the appendix is. String sign is essentially it's often narrowing a lead pipe patient would be a lot more unwell. So none of them really kind of fit in with a picture of diverticular disease or diverticulitis. Okay. So diverticular disease essentially is a patient who has a clinical condition that results from the presence of diverticula. Diverticular is the outpatching of the mucosa. So just to show you a picture, so that's the diverticulum, where the kind of all the layers of the bowel mucosa form kind of an outpouching. Okay, and diverticular disease is the clinical condition that results from the presence of multiple diverticulum. And diverticulitis is when these outpouchings get inflamed. Okay, and that so essentially diverticuli is kind of a lot of people might have it and not know it. Diverticular disease is when patients have some symptoms from caused by diverticuli, and diverticulitis is more of an acute picture of inflammation of these diverticuli. So how do you manage diverticulosis? So in a lot of patients, as we've said, they might have them, they might be asymptomatic, so they might not be quite a lot of to do in terms of management. But essentially the advice for someone who is symptomatic from diverticular is to increase the fiber in their diet, hydrate, and pain management. Okay, and in patients who have quite very symptomatic diverticular disease, which can have aggravated by flare-ups, we might think about surgery. But that is obviously after trying all the lifestyle changes to help them control the symptoms of their disease. And the important one to think about is the complications of diverticulitis. So diverticulitis patients might have PR bleeds, and once we think about PR bleeds, whether they are stable or unstable, if they're unstable, we need to think about immediate management in kind of endoscopic hemostasis, or if that doesn't resolve, is to think about surgery. Okay. Interventional radiology drainage is there an option, because one of the complications of diverticulitis is a diverticular abscess, which might result due to a perforation, a content perforation, and then a formation of an abscess around the area of the diverticulitis. Okay. And essentially, the mainstay treatment would be to try and drain that abscess in the acute setting, and then later on might think about doing surgery. And in an acute perforation where patient is unwell and peritonitic, emergency surgery is only the choice, and that is an emergency Hartmann's. Okay, and emergency Hartmann's involves taking kind of the sigmoid. Diverticulosis is mostly in the sigmoid, taking the sigmoid part of the bowel out and making an end colostomy stoma in the acute setting. That tends to be the choice in a kind of an acute picture, because when there's a lots of infection and inflammation and we try and make a joint between one end of the bowel with the other, that joint is unlikely to heal well, and that's kind of a high risk recipe for having an anastomosis leak in the future. The emergency Hartmann's is kind of the emergency operation of choice in the cases of complicated diverticulitis or unwell diverticulitis in patients. And obviously, as mentioned before, patients with recurrent episodes of diverticulitis or very symptomatic diverticular disease, you think about doing an elective surgery. Okay, so moving on to the next question, a bit of vascular. Okay. Okay, so majority have said answer A, with choice B and E being the other two popular choices. Okay, so surgical anatomy. Okay, so we have a 55-year-old male. They've got a 2-hour history of severe pain in the right leg, and they have a history of rheumatic heart disease. So we're seeing a patient of some cardiovascular history, and they're presenting acutely with pain in the leg, and it's telling us that they're a non-smoker. And the examination findings make us quite worried about the leg. It's telling us it's pale, cold, and it's tender. Okay, and cannot feel the pulses. Okay, and the cap refill is 4 seconds. And they're unable to move their toes, and they have reduced sensation. Essentially, we have indications that's telling us that this is acute limb ischemia. An indication from what they're going on, in addition thinking about the patient has cardiovascular history, is telling us that the pulse is irregular. So that's thinking that the patient has atrial fibrillation. So putting the two together, the patient has atrial fibrillation, and has an acute limb ischemia. We're thinking that this is likely to be secondary to an embolus, and a kind of the emergency management would be a surgical embolectomy. Okay, and we'll go through when we go through the explanation of limb ischemia, we'll go through when surgical bypass and fasciotomy might be an option for management. So, acute limb ischemia, essentially we have severe symptomatic hyperperfusion of a limb, which has happened in the last 2 weeks. And the 6 Ps, which are very important to know, show you the signs of symptoms of acute limb ischemia are pulselessness, painful, pale, paralysis, paresthesia, and perishingly cold. Okay. So the causes, 2 main causes, is either a thrombosis or an embolism. Okay. and thrombosis tends to be second to atherosclerosis. Embolism tends to happen more frequently in patients with atrial fibrillation. Other things that can cause a acute limb ischemia, thinking about external vascular compromise, things like trauma or compartment syndrome, and thinking about that, that's maybe where fasciotomy might kind of play a part as well, or vasospasms such as in Raynaud's phenomenon. Management, obviously this is acute surgical emergency. We need to manage it in an ABCDE approach. Okay, things more, and that is going through all the parts of the ABCDE, but in kind of more things specific for acute limb ischemia, you need to think about oxygen, fluid resuscitation, and pain relief, and blood tests. Thinking about the full blood count and urine electrolytes, but also group and save and clotting. And we are thinking about this patient is likely might need surgical intervention, so we need to have a group and save a clotting screen ready. BBG, look at the lactate, which tells us about a vascular compromise. ECG, thinking about atrial fibrillation, and of course, early involvement of the vascular gene. And things about when kind of you are in the clinical settings, when you see these patients, other things to kind of think about what this patient might need later on. So things you need to keep them nil by mouth, so they might need surgery, and a intravenous heparin might play a part in thrombosis rather than in embolism. Okay. So thinking about where we kind of had the bypass options in the question. So when it comes to thrombotic causes, is that we need to think about it as kind of incomplete or complete ischemia. If it's complete, then it's an urgent bypass surgery. That's the management of choice. Okay, because doing kind of an angio and thinking about thrombolysis, that kind of to map out what thrombolysis is, that will kind of delay to management. Okay, and in things where kind of it's partial, kind of thinking about angioplasties, that might kind of play a part in the management of incomplete ischemia. Embolic causes seem to be presented in a more acute picture. You need to get the embolus out. So the choice is angiography and trying kind of to take the embolectomy, taking the embolectomy out. Thrombolysis might play a part if the embolectomy does not work. Okay, and thinking kind of in acute setting, if it fails to you think about to relieve the ischemia, then amputation might be the last management of choice if all the other treatments fail. Okay, next question. Okay, so it's quite a close one. So most people have either between D, B, and C, D being the most popular answer. Okay, So essentially, this question is about fistulas, and when we think about kind of the direction that they travel and where the internal opening would be, we need to think about Goodsall rule. Let's go through the question, and then we'll go through a diagram of Goodsall rule of where to find the internal opening in an anal fistula. So it's a 27-year-old male, relatively young patient, and they've got some discharge and discomfort around the anus. So we kind of already have some indication that there's a fistula. They have background of Crohn's disease, and Crohn's disease is one of the kind of main risk factors for developing fistulas. And the key thing here to answer the question is that the external opening is anterior, okay? And it's less than 1.5 centimeters from the rectum. So these are really kind of the key things that will help you answer the question. So because it's anterior and less than 3 centimeters from the rectum, is that we need to think about that it's a straight tract. So we'll show you a diagram kind of to explain it why. So, but the two important things to note is that it's anterior and it's less than 3 centimeters from the rectum. So it means it's a straight tract. The internal opening would be a straight tract from the external opening is. So the main things are, as question, symptoms of the anorectal fistula are anal discharge and discomfort. Risk factor is mainly Crohn's disease. You might find the external opening, and you can do a digital PR examination to look for the internal fistula opening. MRI kind of is the kind of after the acute presentation of the fistula. Is the MRI is the investigation of choice to try and characterize where the fistula is, and the MRIs would be kind of done more frequently, of course, in patients with Crohn's disease, because their fistula tends to be more complex, and a lot of the time they do not essentially follow Goodsall's rule. So we'll go through a diagram looking at what Goodsall's rules is. So Goodsall's rules essentially tells us if we can see the external opening, where would we find the internal opening on examination. So in the question, we were told that the external opening is anterior. So in this diagram, it's the bottom part below the blue dot, which represents the anal canal. And so essentially, the internal opening would be a straight line from the anterior part, where the external opening is, to the anal canal. Okay, and that is the important exception to note. That is for if the external opening is less than 3 centimeters from the anal canal. And we'll explain what happens in that exception in a bit. So essentially, if it is posterior, the fistula path follows a curved path as shown in this diagram, rather than a straight line compared to the anterior ones. Now, in the case of the exception that we described, if the external opening is the anterior part, essentially what happens is that it kind of, the fistula path is an curved path that comes where a posterior external fistula would kind of open up in the anal canal as well. So going back to the question, the key phrase is where that it is anterior and that it is within less than 3 centimeters from the anterior part of in front of the anal canal. Is everyone, unfortunately, it's difficult to get feedback, but I do appreciate that there was a bit of confusion answering this question. But we can go through it again if there's any confusion when we get to the question and answer session at the end. Okay. So next question. Okay, so most of you have said option A, which is for laparoscopic repair, with E also an option C and D popular choices as well. Okay, let's go through it. So we have a 70-year-old male, and they've got a lump in the right groin, so we're already thinking this might be a hernia. And they're a smoker, but it's actually, apart from smoking, they have no other past medical history. I'm thinking in terms of when you're kind of in a surgical firm, you need to think, or about if you're a GP, thinking about referring this patient, would this patient be fit for surgery? And so far, there's nothing to indicate otherwise. On physical examination, there's a large lump in the right groin that is superior and medial to the pubic tubercle, and that's kind of indicating for us that it is an inguinal hernia, as it's telling us it's superior and it's medial to the pubic tubercle. And the next sentence is telling us that the patient, when standing, is present when the patient is standing, when there's increased pressure on the abdominal wall, but when they're lying, it does disappear. And that's the next thing is telling us that it is reducible. Essentially, what this is telling us is reasonably fit gentlemen, apart from smoking, that have got an inguinal hernia that is reducible. Okay, so they would be eligible for surgery. So then it comes down is, would we repair this hernia laparoscopically or open? And essentially, laparoscopic you tend to do if there's bilateral hernias. So if there's hernias on two sides. Hernias to do it because then you can do 2 in 1. While open you tend to be if it's kind of a unilateral hernia, you would do an open hernia repair. And then it comes down to either mesh or non-mesh. So you'd always kind of try and opt for mesh repair. The times when you think about not doing a mesh repair is when there's kind of higher risk of infection, because you'd be worried about infection of the mesh. And things about that, we need to think about what does the mesh do when we repair a hernia. Essentially what the mesh is doing is encouraging the body kind of to build a lot of tissues in that area, strengthening that wall after the repair. Okay, so the correct answer is C, open mesh repair. Other things like uterus support, then that's kind of thinking if the patient would not be fit for surgery, but here we have a patient who did present to their GP, so we assume they are keen to have surgery and we have no indication that they're not fit for surgery. Watchful waiting and safety nets designed for strangulation. Of course, when you discharge this patient from the GP after you send them home and tell them to wait for the referral, you would safety net for the signs of strangulation and obstruction. But kind of doing just a watchful waiting, this is if the patient did not want surgery, the patient was not fit for surgery, or it might be done kind of in an accidents and emergency settings where if the patient is kind of just presented acutely with this lump, you just kind of reassure them and tell them, but you tell them to see their GP, ask them to refer them if they want it to be fixed, if you wanted the hernia to be fixed. So essentially the right choice is open mesh repair, refer for open mesh repair. So when we think about inguinal hernia, obviously we said it's either superior or medial to the typical. We think is it direct or indirect? Indirect tends to be in the younger population, direct in the more elderly population. Indirect does happen with patent processus vaginalis congenitally, and direct tends to be more acquired. And there are risk factors to developing a direct inguinal hernia, for example, like heavy lifting. Then helping you in your examination, thinking about a indirect hernia would extend down to the scrotum. A direct would rarely descend to the scrotum. And an indirect goes through the deep ring. And that is kind of, if you're thinking about the deep ring anatomy, it kind of extends the core structure, goes through the deep ring into the scrotum. So essentially because the indirect hernia is following the deep ring, it would kind of descend to the scrotum. And that just rarely happens in a direct hernia, because essentially it's just a defect in the posterior wall. Indirect hernia strangulate, I'm thinking again, because it's going through the deep ring, it's quite a limited space, so there's a risk of strangulation, while direct rarely strangulate. Just covering that it's quite difficult to distinguish direct and indirect through examination. It's really sometimes just at the point of surgery that you're able to direct visualize and that you're able to differentiate the two. Okay, next question. Okay, some of you have said A, which I think is the correct answer. Okay, let's go through it. So you are a FI1, very soon, and on a gastroenterology ward, you are a 53-year-old male. We already have indication. First indication is alcoholic, and he is being managed for acute episodes of pancreatitis, and he is drinking. So we already know that it's pancreatitis, and the likely cause of pancreatitis is drinking alcohol. So we know that it's getting worse. So it was just the question is telling us, thinking about what are kind of putting as indicators of for a severe pancreatitis. And for that, we need to know the modified Glasgow criteria, which we'll go through in a bit. And essentially, the PO2 is borderline, the white cells is not above the threshold, and CRP and sodium are not part of the criteria. The only thing is that we have is positive as part of the criteria is the low calcium or the hypocalcemia. So, go through it quickly. So, causes of pancreatitis. Two things that we need to think about kind of when somebody we think has pancreatitis is think about, do they have gallstones? Do they drink lots of alcohol? These are the two things. Okay, an easy mnemonic to remember, the cause of pancreatitis is get smashed. Unfortunately, you just have to learn them. And they do happen. You do see a pancreatitis in trauma, and you do see pancreatitis with patients, for example, being started on prednisolone. And commonly pancreatitis does happen after ERCP. Unfortunately, that's just another mnemonic to learn. But in real life, the two most important ones to remember is gallstones and alcohol. And this is kind of another mnemonic to try to remember the drug causes of pancreatitis. Okay, and just remember it's these causes as well as steroids. Steroids is commoner kind of cause of pancreatitis than these medications. Okay, so how patients present? They present with epigastric pain. It's quite severe pain. It radiates to their back. Okay, they might be vomiting. And then from your history, as we said, going back to the causes, think about alcohol, think about gallstones. And then if you have these two, then you're thinking this is likely to be pancreatitis. And then need to take as for the medications history, that can give you indication of the cause of pancreatitis. And they might have a fast heart rate and have dry mucous membranes, just a sign that they are dehydrated. And some patients might have fever. However, thinking about the complications of pancreatitis a bit later, we'll know that fever does happen sometimes in a few days after developing pancreatitis as part of the complications. And when you examine the tummy, they're guarding in the tender and the epigastric region. This is Great Turner signs, which is obviously a bruising around the sides, which is kind of a late sign of pancreatitis, and also there's Collins signs, which is bruising around the umbilicus as well, around the belly button. This is a weirdest slide, but it's quite important in understanding the physiology of pancreatitis. So, in pancreatitis, there's third phase fluid sequestration, and that's results of kind of the inflammatory response of the body that increases the permeability of the capillaries. So that leads the fluid coming out from the vasculature into the third spacing. And this can lead to complications of pancreatitis, such as the acute respiratory complications and the dehydration, and resulting in kidney failure. So just understanding this, how kind of pancreatitis can develop, this slide is quite important. So investigations that we need to do is blood tests, the full blood counts, serum electrolytes, C-reactive protein, CRP, and the liver function test as well. We're thinking about if there might be obstructive ducts. But the most diagnostic test is amylase, and it needs to be significantly elevated. And the degree of how much is elevated is no indication of how severe the disease is. We'll go through how to diagnose the severity in a second. Lipase is a better diagnostic test. However, some hospitals have started doing it, but not all the hospitals are doing lipase, but it is a better test. Thinking about other important causes that we need to exclude when we think about pancreatitis, again, comes up is an erect chest X-ray. So kind of in acute abdomen, you need to be thinking, I need an erect chest X-ray to exclude a perforation of a viscus in the abdomen. Ultrasound abdomen, that's thinking if trying to diagnose gallstones. MRCP, we're thinking if we have a blocked biliary duct. So MRCP is the choice to look at where that obstruction is. And if there is an obstruction in the ducts, then you need to be thinking if the patient needs an ERCP. And obviously, what it is, one of the commonest complications of ERCP is pancreatitis itself. A CT scan can be done. It's not done initially when the patient presents to the hospital. It's done really later on, and that's when we're thinking about if the patient develops necrotizing pancreatitis, or thinking if they develop pseudocysts later on. Okay. So to assess the severity, we use the modified Glasgow criteria. Okay. And essentially, we do it when the patient comes in, and 2 days later, and if they score 3 or more, then it is severe pancreatitis, and we need to involve ITU. And this one's quite an easy mnemonic to remember because it follows pancreas. So looking at oxygen, age, white cell counts, calcium, and kidney function, and enzymes and sugars. Unfortunately, I can't remember in med school, but I think we had to learn these numbers, unfortunately. Because they would help you to answer questions like these SBA that we have just done. Okay. In terms of management, we said the primary thing pancreatitis, there is dehydration, hypovolemia. You're losing fluid into the third space. So the main thing in the management is going to be giving fluids to the patient. And essentially, we're likely to give patients likely to need, the severity of pancreatitis is likely to need quite a lot of fluids. That's why this slide says aggressive fluid resuscitation, and use crystalloid solutions like normal saline, 0.9% sodium chloride. And whenever you need to give lots of fluids, you need to be thinking, I need to be measuring what's going in and what's coming out. So essentially, patients like need a catheter, and we normally ask for an hourly fluid balance, essentially wondering how much you're giving them, how much they're taking orally, how much they are peeing or vomiting as well. Painkillers is extremely painful. They're likely to need morphine. Obviously, we follow the WHO ladder, but these patients are very likely to need morphine. Anti-sickness medications. This is really the mainstay treatment, these 4 things. Thinking about other things, antibiotics, that's really if it gets complicated for necrotizing and infections. Calcium, there's a role, but person-person experience, never haven't given calcium, but we do check it and correct it. And insulin, obviously, there's disturbances to the release of insulin and management of glucose. Okay, I think we've hit kind of 1 hour now, so I'll try and kind of do 10 more minutes, and then we'll take the questions and answers so this session does not run for too long. Savannah, please correct me if you'd like me to carry on through all the questions. But yeah, we'll keep going for the next 10 minutes and hopefully take the questions. Okay, so most people have said B, with A, C, and D being other popular answers as well. Okay, let's go through it. So 6-year-old male, 3 months history of cramp in the calf. So essentially we're thinking more is this is a chronic picture. Pain is relieved when they stop walking, so thinking of kind of a claudication picture. They've got comorbidities like hypertension of diabetic, and they've got diminished pulses. So they've got a compromise of the vascular supply to the limbs, and telling us that the ankle breakup pressure index is low as well. So we've got kind of a picture of a chronic limb ischemia. And essentially, we'll go through the answers is that you need to manage the risk factors of this patient. So you need to give them a antiplatelets, and the number one choice tends to be a clopidogrel and a treat cholesterol with a high dose statin. So this normally tends to be atorvastatin 80 milligrams. Okay, so the right choice is B. So chronic limb ischemia, as we said, is we need to think about kind of the risk factors, and essentially they're similar to cardiovascular risk factors like smoking, diabetes, hypertension, high cholesterol, and lifestyle, essentially inactivity and obesity. And it's important to remember these risk factors because the management of chronic limb ischemia is essentially tackling these risk factors. The symptoms is pain in walking, and essentially the indication is that is relieved at rest. It's kind of more chronic. It's not kind of where it's an acute, where this pain is not relieved. And the signs is that you have chronic signs of hair loss, either ulcers, wounds are not healing well, and weaker pulses. The investigations essentially is you're trying to identify the risk factors that I mentioned in the first slide. So looking at glucose levels, the levels of lipids, ECG, thinking, and the assessment in terms of whether there is ischemia, chronic ischemia or not, and that's done via the ankle breakup pressure index. I think you guys just need to know the equation, essentially breakup of the ankle pressure. And the classification in terms of a 1 is around the normal, over 1.2 is abnormal, tends to happen in diabetes, over 0.8 tends to be mild disease, and 0.5 to 8 is moderate, and less than 0.5 is severe. Other things that we can think about is duplex arterial ultrasounds, MR arteriograms, or CT arteriogram. And normally you would start off with doing a duplex scan and then taking it from there whether you would do a MR or a CT arteriogram. Okay, and MR really is your choice because it would help you more kind of when you're thinking about revascularization later on. So this is kind of thinking that this is an diagnostic choice, and then there'll be the therapeutic procedure later on. And again, the management is threefold First thing is the management of the cardiovascular risks. So as we've mentioned, the risk factors. So an antiplatelet, particularly, is the first one of choice. If not tolerated, you go to aspirin. Lipid lowering therapy, and that's kind of the high dose. So 80 milligrams of atorvastatin. If there's management of glycemic control, blood pressure control, and lifestyle choices, kind of like smoking and physical activity. The other part is management of the pain with analgesia. And number 3 is kind of the more definitive management, which kind of might involve surgery. So with intermittent claudication, you try and avoid, so surgery is kind of the last choice. So you try and with the risk factor management and lifestyle choices, and then you would go down the route of thinking about surgery. For a critical limb ischemia, so when it's less than 0.5, the indexes, then you might be thinking about endovascular revascularization. So endovascular tends to be kind of a small part of stenosis. Bypass is when you kind of have a large, long thrombosis, and then you're kind of thinking about bypass options. And last preferable choice becomes amputation if all these fail. Okay. I've tried to look at some images to show you guys what the scars look like. It's actually, I found it quite difficult to find pictures of these scars, but that's kind of a slide telling you what scars to look out for, which might come up as patients or signs in your examinations. So that might be kind of more relevant for your practical examinations, just to know which, with each bypass, what scars you would find clinically on examination. I think there are 2 more questions, but I think it is 11 past, so I think we will stop there and try and take some questions. The last 2 questions that are left kind of look at mesenteric adenitis and appendicitis and look at abdominal aortic aneurysms and its management and the screening program. So I'm sure Quesmed would share the slides with you later on. So I'll just start by taking the questions now, just for the, obviously, because we have been going on for 70 minutes. So I'm just trying to open the Q&A. The last one says, please continue. Savannah, do you think I should continue or start answering questions?
You can continue for a little bit longer if you would like, if that's what people want to do.
Just one person says, okay, they want to finish the questions. Okay, sure. Well, so yeah, go for it, guys. Okay, so most people have said C, mesenteric adenitis, which I think is the correct answer. Let's go through the question. So we have a 7-year-old boy, so a young patient. They've got this pain that's diffuse, got an unspecific history of the location of the pain, but it seems quite significant. They're not able to run. So that's indication that they're quite unwell. But first thing that's giving us clues is that there's a sore throat, but which got better after 2 days. They haven't vomited, but they haven't eaten. They haven't opened their bowels the past 2 days. When you examine them, the pain is kind of not specific, but there is swelling on the right side. Temperature, blood pressure, and heart rate seems okay. And you have the ultrasound findings that suggest enlarged lymph nodes. So with the sore throat and with the ultrasound findings and observations of a recently well child, it's kind of indicating for you that this is likely to be a mesenteric adenitis. Essentially, this question is trying to get you to differentiate between acute appendicitis and mesenteric adenitis. But it's also important to think about why it's not the other three as well, because the other three are common interruption, not in this age group. Necus diverticulum can happen, but patient tends to happen as perforated diverticulum, so patient would be more unwell. And to constipation, the patient is just not opened their bowels for 2 days, so we can't make that diagnosis on such a short history, especially we have positive findings for other things that suggest this answer C. So, appendicitis, common presentation. Essentially what it is there's inflammation of the appendix, pain starts centrally and then radiates to the right iliac fossa. Nausea, that is an important sign. So a patient who says they are hungry, they're probably unlikely to have appendicitis. They should be kind of feel that they're off their food. They might have some discrete episodes of vomiting, and they might have some fever. And it's important to note that it's a low-grade fever. It is not a temperature of 39 or 40, for example. If it is that high, then that might give you an indication there's a viral illness involved in a child. And Jovsing signs, this essentially means is that when you palpate the left iliac fossa, the patient reports pain on the right side. Investigations tends to be you do urine test, excludes a urine infection, pregnancy test, obviously not in the choice of this question, but obviously to exclude, we're thinking about ectopics, and blood tests. And the blood tests you do for blood counts and CRP, looking for high infection markers. You'd still do a re-an electrolyte, thinking about clotting screen and a group and say, because thinking this patient might need surgery later. CT is a lot better at diagnosing appendicitis than ultrasound, but obviously because of the age group that tend to present is they're quite young, so we're trying to avoid the high dose radiation of a CT, so we always go for an ultrasound. And essentially, in males, in young males, we rarely do kind of a investigation kind of imaging if we are quite confident from the clinical history and the simple blood test that this is appendicitis, because an ultrasound is not that great at picking it up. So we'd go more with the clinical picture and the simple investigation results. Ultrasound, however, in young females, we'd always do, because we need to identify whether the presentation is related to an ovarian pathology, for example, things like a ruptured cyst, which can cause quite significant sharp pain. And in some cases, a ruptured cyst can also cause an increase in inflammatory markers. But the presentation of a ruptured cyst will be more acute, sudden onset pain, while appendicitis is more of a build-up of pain. The management is antibiotics, and there is a lot of studies out there that suggest you could treat appendicitis just with antibiotics. However, the mainstay treatment in the UK tends to be a laparoscopic appendicectomy. Unless not possible or complicated, then you would do an open appendicectomy. And we treat appendicitis surgically to avoid the complications, which are perforation and formation of an abscess. And obviously from surgery, complications that can result are wound infections and adhesions in the future. The other important differential in peds is to think about mesenteric adenitis. As mentioned before in reading the question, is that it tends to present with more unspecific diffuse abdominal pain, and there is some signs of an upper respiratory tract infection. And unfortunately, sometimes the ultrasound might help and show an enlarged lymph nodes, and that will give you kind of a a lot more confidence that this is a mesenteric adenitis rather than appendicitis. But a lot of the time, kind of investigation, looking kind of at the throat to look for signs of infection to help make this diagnosis clinically. Looking for pharyngitis or kind of inflamed tonsils. Okay, I think this is the last question. So go for it, guys. So most of you said C. Unfortunately, with this sort of question is that you just need to know the fact that in the UK, we'd recommend elective repair for an aortic aneurysm when it's 5.5 centimeters. Okay, so we'll just go through briefly about AAAs. So you call it an aneurysm when it's over 3 centimeters. The commonest sites for it is between renal and inferior mesenteric arteries. And then you think about repairing it. If it's over 5.5 centimeters, you'd recommend repair this 5.5 centimeters, obviously in fit patients. Or there's rapid expansion. And rapid expansion, I think this is a common, commonly mentioned in SBAs, is that if it increases by more than 5 millimeters over a 6-month period or 10 millimeters over a year. So it depends either in the absolute size or the progression in size of the aneurysm. Most people with aneurysm, they're likely to be asymptomatic. They might report a mass that's going to be kind of pulsatile in examination. Now, obviously, the other type of presentation is kind of an emergency sort of thing, and that patients are to be acutely unwell. Now we're talking about kind of aneurysms that are elective setting. The surgical options, there are two. It's either open repair or endovascular repair. And really the mainstay is endovascular repair. They kind of is the choice if the patient is not as fit as a surgical candidate, so kind of in terms of comorbidities or kind of their exercise tolerance. And the other thing is when you choose endovascular repair is depending on the extent of the aneurysm and if it involves the renal vessels as well. So not every aneurysm would be possible to fix through the endovascular route. So that's really kind of the consideration that come into place when thinking about EVA and when thinking about open repair. For fit patients, have no comorbidities, they're likely to tend to go for open repair. And the ones with kind of more complicated aneurysms, or again, they're more likely to go for open repair. In the UK, there's a screening program, and it's offered to men over the age of 65. And that kind of slide tells you how often you would repeat the scan, just for the sake of answering a SBA if it comes up, and obviously to know it. And how often you repeat the scan. And obviously over 5.5, you refer to have surgical management. Okay, and I think this is the last slide. This is just a slide that we put kind of just to cover scars because it's kind of a common thing. But I think we'll start answering questions now, just for the sake of time.